Cancers are the most common type of cancer for people around the world. One of its features is the fact that it metastasizes rarely. However, it can determine local destruction and severe disfigurement if neglected or poorly treated. Prognosis is excellent if approached correctly. If allowed to progress, on the other hand, it can lead to significant morbidity. Basal cell carcinoma. Basal cell carcinoma is a type of skin cancer that begins in the basal cells, a type of cells within the skin that produces new skin cells as old ones die off. It sums up to almost 20% of all human cancers. Basal cell carcinoma often appears as a slightly transparent bump on the skin, though it can not take other forms too. It occurs most often on areas of the skin that are exposed to the sun, such as the head and the neck areas. Given these informations, can you guys take a wild guess as to where geographically you are most likely to encounter this type of disease? Are we talking about equatorial regions, the poles, temperate climates? Think it through. What's the main cause for skin cancers?
The sun.
Exactly. So, knowing that, do you think it occurs more often in the equatorial regions, or let's say the northern countries of Europe?
The equatorial.
Exactly. Not only is it closer to the sun due to the bulge of the earth, but you pretty much have no seasons, you have long days, and you pretty much have sun exposure throughout the entire year, okay? Symptoms-wise, less often, basal cell carcinoma can develop on parts of your body usually protected from the sun, such as the genitals or feet. It appears as a change in the skin, such as a growth or a sore that won't heal. These lesions usually have one of the following characteristics. First, a white, pearly, skin-colored, or pink bump that is translucent, meaning you can see a bit through it. Tiny blood vessels are often visible. In people with darker skin tones, the lesions may be darker but still somewhat translucent. The most common type of basal cell carcinoma, this lesion often appears on the face and ears. The lesion may rupture, bleed, and scab over. It can also appear as a brown, black, or blue lesion, or a lesion with dark spots, with a slightly raised translucent border. It can also take the shape of a flat, scaly, reddish patch with a raised edge, which is most common on the back or chest. Over time, these patches can grow quite large in dimension. A white, waxy scar-like lesion can also develop without a clearly defined border. This is called a morpheaform basal cell carcinoma. Loss of vision can occur if nerve involvement is present, along with the possibility for said tumor to extend deeper into the affected tissue. These tumors are frequently brittle and prone to ulcerations, which leads to a higher risk of them getting infected. It's an affliction that mostly targets the white race, especially the fair skin subtypes. More melanotic skin types have a lower risk of developing basal cell carcinoma. Why do you think that's the case?
Because of melanin.
Okay, which does what when coming into contact with UVB rays? Darker skin tones tend to disperse the radiation throughout the entire surface and absorb less light than white skin does, okay? Sex-wise, a ratio of 3 to 2 places men at a higher risk of developing this affliction than women. Causes. Basal cell carcinoma occurs when one of the skin's basal cells develops a mutation in its DNA. Basal cells are found at the bottom of the epidermis, the outermost layer of the skin. Basal cells produce new skin cells. As new skin cells are produced, they push older cells towards the skin surface, where the old cells die and are sawed off. The process of creating new skin cells is controlled by a basal cell's DNA. The DNA contains the instructions that tell a cell what to do. The mutation tells the basal cell to multiply rapidly and continue growing when it would normally die. Eventually, the accumulating abnormal cells may form a cancerous tumor, the lesion that appears on the skin. Much of the damage to DNA in basal cells is thought to result from the ultraviolet or UV radiation found in sunlight and in commercial tanning lamps and tanning beds. But sun exposure doesn't explain skin cancers that develop on the skin not ordinarily exposed to sunlight. Other factors can contribute to the risk and development of basal cell carcinoma, and the exact cause may in some cases not be clear. Risk factors. First and foremost, chronic sun exposure. A lot of time spent in the sun or in commercial tanning beds increases the risk of basal cell carcinoma. The threat is greater if you live in a sunny or high altitude location, such as, let's say, Peru, both of which expose you to more UV radiation. Severe sunburns also increases your risk. Radiation therapy. Radiation therapy to treat acne or other skin conditions may increase the risk of basal cell carcinoma at previous treatment sites on the skin. Fair skin. The risk of basal cell carcinoma is higher among people who freckle or burn easily, or who have very light skin, red or blonde hair, or light-colored eyes. Increasing age. Because basal cell carcinoma often takes decades to develop, somewhere between 20 and 50 years, the majority of basal cell carcinomas occur in older adults, but it can also affect younger adults and is becoming more common in people in their 20s and 30s recently. Another risk factor is a personal or family history of skin cancers. If you've had basal cell carcinoma one or more times, you have a good chance of developing it again. If you have a family history of skin cancer, you may have an increased risk of developing basal cell carcinoma in the future. Immune suppressing drugs. Taking medication that suppresses your immune system, such as anti-rejection drugs used after transplant surgery, significantly increases your risk of skin cancer. Exposure to arsenic. Arsenic, which is a toxic metal that's usually found widely in the environment, increases the risk of basal cell carcinoma and other cancers. Everyone has some arsenic exposure simply because it occurs naturally. But some people may have a higher exposure if they drink contaminated well water or have a job that involves producing or using arsenic. Inherited syndromes that cause skin cancers. Certain rare genetic diseases can increase the risk of basal cell carcinoma, including nevoid basal cell carcinoma syndrome, or the Gordon-Goltz syndrome, and last but not least, xeroderma pigmentosum, which we'll be talking about further on. A lattice period of 20 to 50 years is typically usual between the initial lesion and the clinical onset of the ailment. Arsenic exposure has also been linked with developing this type of disease more often in the late 80s to early 90s. A history of non-melanotic skin cancers. People who have had non-melanotic skin cancers prior to the basal cell carcinoma are at a greater risk of developing others in the future. The frequency of new onset skin cancers is 30% at 3 years, which goes all the way up to 50% at 5 years after the initial diagnosis. Complication-wise, we have a risk of recurrence. Basal cell carcinomas commonly reoccur even after successful treatment. An increased risk of other types of skin cancer. A history of basal cell carcinoma may also increase the chance of developing other types of skin cancers, such as squamous cell carcinoma, which is the second most common type of skin cancer, followed directly after the basal cell one. Cancer that spreads beyond the skin. Very rarely, basal cell carcinoma can spread or metastasize to nearby lymph nodes of the body, such as the bones and lungs. Which one of these two do you think is the most deadly? At which point it renders the disease incurable? The bones or the lungs as a prime site for metastasizing?
Lungs.
Exactly. What can we do to prevent it? Avoid the sun during the middle of the day. In many places, the sun's rays are at their strongest between about 10 a.m. all the way up to 4 p.m. Schedule outdoor activities for other times of the day, even during winter or when the sky is cloudy. Wear sunscreen year-round. Use a broad-spectrum sunscreen with an SPF of at least 30, even on cloudy days. Wear protective clothing. Cover your skin with dark, tightly woven clothing that covers your arms and legs, and a broad-brimmed hat, which provides more protection than does a baseball cap or visor. This is another niche of pathology that we're going to get into. Let's take northern people as an example. Most of them do have fair skin. You aren't being exposed to that much sunlight in Norway or Finland or Sweden. However, if you're the type of person that takes vacations for a couple of months a year in tropical areas, the risk of developing mutations that would lead to a type of skin cancer in the future are much higher than people of a darker skin tone, okay? Avoid tanning beds. Check your skin regularly and report changes to your physician. Examine your skin often for new skin growths or changes in existing moles, freckles, bumps, and birthmarks. With the help of a mirror, check your face, neck, ears, and scalp. It doesn't take much, but it can go a long way. Examine your chest and trunk and the tops and undersides of your arms and hands. Examine both the front and the back of your legs and your feet, including the soles and the spaces between your toes. Diagnosis. History and general exam. The physician will conduct a general physical exam and ask the patient about their medical history, changes in their skin, or any other signs or symptoms they've experienced. Questions may include: when did you first notice the skin growth or lesion? Has it changed since you first noticed it? Is the growth or lesion painful? Do you have any other growths or lesions that concern you? Have you had a previous skin cancer? Has anyone in your family had previous skin cancer? And if yes, what sort? Do you take precautions to stay safe in the sun, such as avoiding midday sun and using sunscreen? And finally, do you examine your own skin on a regular basis? Treatment-wise, the goal of the treatment for basal cell carcinoma is to remove the cancer completely. Which treatment is best for the patient depends on the location, the size of the tumor, as well as the preferences and abilities to do follow-ups for the patient. Treatment selection can also depend on whether this is a first-time or a recurring basal cell carcinoma. Recurring ones are way more aggressive and more difficult to treat. Surgery. Basal cell carcinoma is most often treated with surgery to remove all the cancer and some of the healthy tissue around it. Options may include surgical excision. In this procedure, the doctor cuts out the cancerous lesion and the surrounding margin of healthy skin around it. The margin is then examined under a microscope to make sure there are no cancer cells that have microscopically spread further than the tumor itself. Excision might be recommended for basal. Okay, so basal cell carcinoma is most often treated with surgery to remove all the skin, all of the cancer, and some of the healthy tissue around it. Options might include surgical excision. In this type of procedure, the doctor cuts out the cancerous lesion and the surrounding margin of healthy skin around it. The margin is then examined under a microscope to make sure there are no cancer cells left. Excision might be recommended for basal cell carcinomas that are less likely to occur, such as those that form on the chest, back, hands, or feet. Moss surgery. During Moss surgery, the doctor removes the cancer cell layer by layer, examining each layer under the microscope until no abnormal skin cells remain. This allows the surgeon to be certain the entire growth is being removed and avoid taking an excessive amount of surrounding healthy tissue with it. Moss surgery might be recommended if your basal cell carcinoma has a higher risk of reoccurring, such as if it's larger, extends deeper in the skin, or is located on the face. Other types of treatments: curettage and electrodesiccation, also known as CNE. CNE treatment involves removing the surface of the skin cancer with a scraping instrument, a curette, and then searing the base of the cancer with an electric needle. CNE might also be an option for treating small basal cell carcinomas that are less likely to reoccur, such as those that form on the back, chest, hands, and feet. Radiation therapy. Radiation therapy uses high-energy beams, such as X-rays, protons, photons, or electrons, to kill the cancer cells. It's sometimes used after the surgery when there is an increased risk that the cancer will reoccur. It might also be used when surgery is not an option. Other types of procedures. Freezing. This treatment involves freezing cancer cells with liquid nitrogen, procedure also known as cryosurgery, and it may be an option for treating superficial skin lesions. Freezing might be done after using a scraping instrument, curette again, to remove the surface of the skin cancer. Topical treatments. Prescription creams or ointments might be considered for treating small and thin basal cell carcinomas when surgery isn't an option. Photodynamic therapy, or PDT, combines photosensitizing drugs and light to treat superficial skin cancers. During PDT, a liquid drug that makes the cancer cells sensitive to light is applied to the skin. This excites the porphyrins, which are then activated by shining blue light upon them. That destroys the skin cancer cells that are being shone upon. PDT therapy might be considered when surgery isn't an option. Treatment for metastasized stages. Very rarely, basal cell carcinoma may spread or metastasize to nearby lymph nodes and other areas of the body. Additional treatment options in this situation include targeted drug therapy. Targeted drug treatments focus on specific weaknesses present within the cancer cells. By blocking these weaknesses, targeted drug treatments can cause cancer cells to die. Targeted therapy drugs for basal cell carcinoma block molecular signals that enable the cancers to continue growing. They might be considered after other treatments or when other treatments aren't possible. Chemotherapy. Chemo uses powerful drugs to kill the cancer cells. As a main agent, we have 5-fluorouracil, which is being used for treating superficial tumors. It has a success rate close to 80%. However, it is limited in its effectiveness by the poor skin penetration, only 1 millimeter in depth. It works on tumors that are small enough as to not be seen with the naked eye. Upsides, cosmetic results vary from good to excellent since there's no deformity involved in applying topical treatments to the skin. Alpha-2b interferon. It has shown success in treating small, superficial, and nodular subtypes of BCC. Success rate, much like 5-fluorouracil, ranges around 80%. It's limited in use due to its high cost, multiple visits to the physician, administering discomfort, and side effects varying from mild flu symptoms to cardiovascular, neurological, and immune depressive ones. One thing to take home, being an immune stimulant, it must not be used to treat basal cell carcinomas for patients who have underwent organ transplant or suffer from any autoimmune afflictions. Prognostics. Improperly treated BCC can reoccur. All treated areas must be closely monitored after undergoing therapy. Patients with BCC have a 30% higher risk of developing other types of unassociated cancers compared to the general population. The second entity, squamous cell carcinoma. I'll be making this pretty quick since I've already wasted 25 of your guys' minutes. Squamous cell carcinoma of the skin is a common form of skin cancer that develops again in the squamous cells that make up the middle and outer layers of the skin. It makes up 20% of the whole skin cancer group. Squamous cell carcinoma usually is not life-threatening, although it can be aggressive. Untreated squamous cell carcinoma can grow large or spread to other parts of the body, causing serious complications. Most forms of squamous cell carcinoma are treated and lead to minimal trauma. A subset of high-risk lesions indicate a high morbidity rate. These lesions can lead to extensive tissue damage along with cosmetic deformity upon treatment. The risk itself of metastasizing sits around 2 to 6%, although cases of 47% have been reported when nerves were affected. Lymph node metastases are linked with a high morbidity index. Once pulmonary metastases have been confirmed, the disease becomes incurable. Low-risk tumors are being cured through surgery. However, people afflicted with SCC have a 30% chance of ending up with other squamous tumors in the next 2 years. Said risk increases with patients' age. Patients need to be evaluated every 6 to 12 months. However, high-risk patients require skin and lymph node evaluation every 3 to 6 months for at least 2 years since the confirmation. Symptoms-wise, signs and symptoms may include a firm red nodule, a flat sore with a scaly crust, a new sore or raised area on an old scar or ulcer, a rough scaly patch on the lip that may evolve into an open sore, a red sore or rough patch inside the mouth, a red raised patch or wart-like sore on or in the anus or on the genital area. Typical age of presenting to the physician is 70 years. But in some high-risk groups, it can manifest itself much earlier, even talking about late 20s to early 30s. Whenever muscle weakness and tremor are involved, we can already talk about nerve implication. Risk factors. As with the basal cell carcinoma, we have fair skin. Anyone, regardless of skin color, can get squamous cell carcinoma. However, having less melanin in your skin provides less protection from damaging UV radiation, hence an increased risk of developing the disease. If you have blonde or red hair, light-colored eyes, or you freckle or sunburn easily, you're much more likely to develop skin cancer, including squamous cell carcinoma, than a person would do if it had a darker skin tone. Excessive sun exposure. Being exposed. Told you guys about the risk factors.
Yes.
You've heard that bit?
Yes.
Okay, fair. So, complications. Untreated squamous cell carcinoma of the skin can destroy nearby healthy tissue, spread to the lymph nodes or other organs, and may be fatal, although this is pretty uncommon. The risk of aggressive squamous cell carcinoma of the skin may be increased in cases where the cancer is particularly large or deep, where it involves the mucous membranes, such as the lips, or when it occurs in a person with a weakened immune system, such as someone who takes anti-rejection medication after an organ transplant or someone who has chronic leukemia. For diagnosis, we have the physical exam, which will be done by the physician, where he will ask about the patient's personal history and health history and examine the skin to look for any particular signs that may indicate this.
Excuse me, we can't hear you anymore.
I texted him now.